So now getting to the meat and potatoes, what we all came here for. I have the pleasure of introducing to you our speaker today, Miss Amy Ward. She is with LASORD, which stands for Louisiana Autism Spectrum and Related Disability Project. And she is going to provide us this information on fetal alcohol spectrum disorder. We were talking a little earlier about the buzz around this and how important this information is. So I don't want to waste any time. I want to go ahead and turn over to Miss Amy and let her get started. So thank you again, Amy, for joining us today and providing us with this valuable information.
Good morning, everyone. Thank you for joining us. Thank you, Miss Janelle, for introducing me. I appreciate that. My name is Amy Ward, and I work with the FASD initiatives at LSU Health New Orleans's Human Development Center. We're going to talk about fetal alcohol spectrum disorders, usually shortened to FASD. We look at what FASD is, how it can affect developmental behavior, learning, and daily life, and what families and community partners can do to provide effective support. You do not need to have any previous knowledge of FASD to participate today. My goal is to explain the information in a way that is understandable, practical, and useful. At the end of the presentation, you are welcome to type a question in the chat or unmute and ask a general question. But because this is an open webinar, please do not share names or identifying details about a child, family member, student, or client. If you have a personal or situation-specific question, please email me after the webinar. I'll be happy to help you. My email will be given at the end of the webinar. I will be happy to connect with you privately and help you think about resources or possible next steps. Looks like in the chat, we've been given some contact information for, see, who did that say? For Mimi Webb. Before we begin, I do want to tell you briefly about the Human Development Center, or HDC as we call it. HDC is part of LSU Health New Orleans. We are Louisiana's University Center for Excellence in Developmental Disabilities, also called a USED. We love acronyms in education. Our work focuses on improving opportunities and outcomes for individuals with disabilities and their families throughout the lifespan. That includes early childhood, school-age services, the transition from school into adult life, employment, community participation, and health. We provide direct services, professional development, technical assistance, and interdisciplinary training. Our programs address many areas, including inclusive education, autism, deaf-blindness, FASD, employment, transition services, community health, and benefits planning. Although today's topic is FASD, the larger goal of our work is to help communities build systems that are more inclusive, responsive, and supportive of people with disabilities and their families. As I mentioned, my name is Amy Ward. I have a master's degree in special education, and much of my work focuses on helping people with disabilities, families, educators, and community systems work together more effectively. My role with LASORD, I support schools and educators in strengthening inclusive practices and improving support for students with disabilities. Through FASD initiatives, I provide education and help professionals and families better understand FASD as a lifelong brain-based disability. With Paycheck, I support transition planning and help schools strengthen the systems that prepare young people with disabilities for adult life, employment, and community participation. In LEND, I coordinate community, clinical, and inclusive experiences that help trainees learn from professionals, families, self-advocates, and community partners. These roles overlap in many ways. Across all of them, my work is really about helping people understand needs more clearly, build practical supports, and create better opportunities for individuals with disabilities and their families. I'm not here today to diagnose anyone or to tell families what a specific child does or does not have. My goal is to share information that may help families and professionals recognize patterns, ask better questions, and provide more effective support. FASD is much more common than many people realize. Research has estimated that as many as 1 in 20, I'll say it again, school-age children may be affected by prenatal alcohol exposure. That means most schools, service systems, healthcare settings, and community programs are likely already supporting people with FASD, whether those individuals have been identified or more likely not. Despite the prevalence, FASD remains under-recognized and underserved. Many people are familiar with autism or ADHD, but they may not know or may know very little about FASD. There are also fewer diagnostic resources, fewer trained professionals, and fewer services specifically designated or designed for individuals with FASD. The financial impact is also significant. The costs can include healthcare, special education, mental health services, disrupted employment, involvement with the justice system, and long-term support needs. But the real impact cannot be measured only in dollars. Families may spend years trying to understand why common parenting, teaching, or behavior strategies are not working. Individuals may be repeatedly blamed or punished for things connected to how their brains process information. Awareness matters because understanding changes how we respond. Even the prevalence estimates we may not show the full picture. One reason is that there is no consistent system for screening and identifying FASD. Access to knowledgeable diagnostic teams is limited, and the process can vary widely from one community to another. Another challenge is that the characteristics of FASD can look similar to other conditions. A person may first be diagnosed with ADHD, a learning disability, autism, a language disorder, anxiety, oppositional behavior, or another condition. Those diagnoses may describe real needs, but they may not explain the full pattern. Stigma is another major barrier. Families may fear being blamed or judged if prenatal alcohol exposure is discussed. Birth parents may not remember, may not know they were pregnant at the time, or may not feel safe sharing the information. Professionals may also avoid asking because they are uncomfortable with the topic or don't know how to ask without sounding judgmental. Finally, many educators, healthcare providers, social workers, and community professionals receive little formal training about FASD. All of this means that many individuals may live with the effects of prenatal alcohol exposure without anyone recognizing the underlying cause. FASD is an umbrella term rather than one single diagnosis. The term includes several conditions associated with prenatal alcohol exposure. You may hear terms such as fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, alcohol-related birth defects, or neurobehavioral disorder associated with prenatal alcohol exposure. The terminology can be confusing because diagnostic guidelines and the terms are used by different professionals, and those have changed over time. For families, the most important point is not memorizing every diagnostic label. The important point is that prenatal alcohol exposure can affect how the brain and how the body develop. Those effects can vary greatly from one person to another. One individual may have significant learning and memory difficulties, but no visible physical characteristics. Another may have medical concerns, developmental delays, and challenges with daily living skills. Some individuals may have average or above average intelligence, but still need substantial support with judgment, organization, emotional regulation, or independence. FASD is a spectrum because there is no single presentation that describes everyone. It is also lifelong. Children with FASD grow into adults with FASD, although their needs and strengths may look different over time. Prenatal alcohol exposure can affect the way the brain develops and functions. Some of the areas commonly affected include memory, attention, cause and effect, reasoning, and self-regulation. For example, a child may listen to a direction, appear to understand it, and then genuinely forget what was said only a few minutes later. A young person may know a rule and be able to repeat the rule, but still fail to use it in the moment. Someone may understand a consequence after it happens, but have difficulty using that past experience to guide a future decision. Self-regulation can also be difficult. A person may become overwhelmed quickly, have difficulty calming down, or react strongly to something that appears minor to other people. These responses are often interpreted as carelessness, defiance, manipulation, or a lack of motivation. But when the difficulty is connected to brain development, the person may not be choosing that behavior in the way that other people assume they are. That does not mean we ignore unsafe or inappropriate behavior. It means we respond by teaching, supporting, supervising, and adjusting the environment rather than relying on punishment. It's very important that we do not talk about FASD only in terms of deficits or problems. Individuals with FASD have strengths, interests, personalities, and abilities that are not captured by a diagnostic label. Many individuals are creative, determined, friendly, helpful, very artistic, energetic, affectionate, or eager to connect with others. Some are very strong visual learners. Some learn well through movement, demonstration, repetition, music, or hands-on experience. Many want to succeed and want the adults around them to be pleased with them. The desire to please can be a strength, but it can also create vulnerability. A person may agree with an adult, say they understand, or accept blame because they want the interaction to end positively. When we identify and build on a person's strengths, we can create more opportunities for success. Support should not limit or should not be limited to correcting what a person cannot do. It should also help the person use what they do well. Primary disabilities are the direct effects of prenatal alcohol exposure on the developing brain and body. These may include difficulties with memory, attention, language, and information processing, motor development, learning, and overall development. Information processing is especially important to understand. A person with FASD may need more time to hear information, understand what it means, decide how to respond, and then carry out the response. When adults repeat the direction more loudly or add more words, the person may become even more overwhelmed. Language can also be uneven. Someone may speak very well and use a large vocabulary, but have difficulty understanding complex language. This can create what is sometimes called the illusion of competence. Because the person sounds capable, adults assume that their understanding and daily functioning are equally strong. A person may also perform a skill successfully one day and struggle with the same skill the next day. That inconsistency can be frustrating, but it is common in FASD. It does not necessarily mean the person is refusing to cooperate. The more we understand the primary disability, the less likely we are to mislabel the person as lazy, careless, oppositional, or manipulative. Prenatal alcohol exposure can affect several higher level brain functions. Abstract thinking is one example. Abstract ideas are things that we can't see easily or touch, such as responsibility, respect, honesty, consequences, or doing your best. A child may need these ideas translated into concrete, observable actions. Cause and effect reasoning can also be difficult. The person may not automatically connect an action today with a consequence that will happen later. Generalization is another common challenge. Generalization means taking something learned in one setting and using it in another. A child may learn how to follow a routine at school, but not recognize that a similar routine applies at home. An adult may know how to complete a task with one supervisor, but struggle when the location or the people or the materials change. Memory difficulties may affect routines, appointments, instructions, and safety. Relationships and attachment can also be affected, especially when neurological differences are combined with early adversity, disrupted caregiving, or trauma. Changes related to sexual behavior may involve boundaries, challenges, not changes, sorry, may involve boundaries, social understanding, impulse control, vulnerability, and difficulty recognizing unsafe situations. These concerns require direct teaching, supervision, repetition, and clear expectations, not shame. FASD can affect both the brain and the body. Neurological and developmental characteristics may include poor coordination, hyperactivity, difficulty maintaining attention, learning disabilities, speech and language delays, intellectual disability, and poor reasoning or judgment. However, not every person will have all of these characteristics. Intellectual ability can vary greatly. Some individuals have an intellectual disability, while others have average or above average intelligence. Physical effects may include low body weight, shorter than average height, a smaller head size, vision or hearing concerns, or heart, kidney, or bone problems. Some individuals with fetal alcohol syndrome may have particular facial characteristics, but most people with FASD do not have obvious physical signs. That's another important point. You cannot determine whether someone has FASD simply by looking at them. Most of the challenges are related to brain functioning and therefore are invisible. The absence of physical characteristics doesn't mean the person hasn't been affected by prenatal alcohol exposure. It's also important not to use this list as a checklist to diagnose a child or adult. Many of these characteristics can occur for other reasons. A full evaluation requires appropriately trained professionals and information from multiple sources. This visual illustrates one of the most important concepts to understand for FASD. The person shown is 18 years old chronologically. On the outside, this young adult may look like other 18-year-olds. People may assume that an 18-year-old should be able to manage time, money, relationships, responsibilities, and personal safety independently. But development in FASD is often uneven. In this example, expressive language may appear to be at a 20-year-old level. The person may speak well, use adult vocabulary, and sound confident. The reading ability may be closer to age 16, but daily living skills may function closer to age 11. Understanding time and money may be closer to age 8. Social skills may be closer to age 7, and comprehension or social maturity may be closer to age 6. The exact ages on this visual are only an example. Every person has an individual pattern. The lesson is that the chronological age, their physical appearance, and their verbal ability do not always tell us what level of support someone needs. This mismatch can place a person at a significant risk. They may look old enough to manage independently and sound capable of making adult decisions, but they may not fully understand consequences, danger, when they're being manipulated, contracts that they're signing, money, or social expectations. This is one reason individuals with FASD may be given too much independence too quickly. We need to look at functional ability rather than assuming that the age alone determines readiness. The shift goes from asking, why won't this 18-year-old act 18, to asking, what skills does this person have? Where are the gaps and what support will help them? This slide describes adverse outcomes that have been reported among children, youth, and adults with FASD. These can include disruption in school, substance use concerns, trouble with the law, confinement in detention or treatment settings, inappropriate sexual behavior, and difficulty living independently. This can be frightening information for families to hear, so I want to be very clear. These outcomes are not inevitable. They're often called secondary impacts because they're not considered the direct brain-based disability itself. They may develop when the person's primary disabilities are misunderstood or unsupported. For example, a child with memory difficulties may be repeatedly punished for forgetting. A student who cannot regulate effectively may be suspended instead of taught regulation skills. A teenager with poor social judgment may be easily influenced by peers. An adult who has difficulty understanding money, time, or contracts may be expected to live independently without enough support. Repeated failure, punishment, rejection, trauma, and misunderstanding can build over time. Protective factors make a difference. These include early identification, stable relationships, appropriate expectations, consistent support, safe environments, effective mental health services, and adults who understand the disability. The purpose of discussing these risks is not to predict a negative future, it's to show why informed support matters. Individuals with FASD may be particularly vulnerable during interactions with the police or the justice system. A person may take blame because they want to please the authority figure or protect someone else. They may panic and run because they're frightened or overwhelmed. They may say they understand their rights because they don't want to appear confused. They may agree to a search without understanding what they've agreed to. They may answer questions impulsively, change their answer, fill in memory gaps, or make statements that worsen the situation. These behaviors may be interpreted as guilt, being dishonest, or having a lack of remorse. However, memory, language, comprehension, suggestibility, impulse control, and cause and effect reasoning may all be involved. This does not mean individuals with FASD cannot be held accountable or cannot learn. It means that communication and legal processes may need to be adjusted. They may need simple language, additional time, legal representation, repetition, visual information, and checking for genuine understanding. Families may also need to teach safety and rights directly rather than assuming a young person will understand them from general conversations or from school lessons. FASD creates significant costs for individuals, families, communities, and public systems. Those costs may include healthcare, education, mental health services, substance use treatment, unemployment, homelessness, and justice system involvement. At the same time, funding for FASD awareness, identification, research, and intervention has historically been limited. Prevention is important, but prevention should not be the only focus. People who are already living with FASD need identification, appropriate services, and support throughout their lives. Families need professionals who understand the disability and do not blame them when traditional approaches fail. Investment in early identification and FASD-informed support can reduce later crises and improve quality of life. The earlier we understand what's happening, the earlier we can adjust expectations, teach skills differently, and put protective supports in place. Support is not about lowering expectations. It's about providing the structure and accommodations that allow the individual to succeed. We're now moving from understanding the disability to discussing what we can do. The three categories on this slide are visual supports, positive behavior supports, and sensory supports. These strategies are not limited to schools. They can be used at home, in healthcare settings, in community programs, at work, and in adult services. They're also not only useful for people with a confirmed FASD diagnosis. Many individuals benefit from clear visual information, predictable routines, proactive behavior supports, and sensory accommodations. Well, I guess I should say everybody does, because I know I do too. A central idea in FASD informed support is that we often need to change the environment around the person rather than continually demanding that the person adapt to an environment that isn't working for them. We may need to reduce language, make information visible, break tasks into smaller steps, repeat teaching, provide supervision, or create more predictable routines. The goal is not dependence. The goal is successful functioning. Sometimes support is what makes the independence possible. Let's see. There we go. Visual supports make information visible. Many daily expectations are usually communicated verbally. We tell someone what to do, where to go, how long something's going to last, what is happening next. For a person with memory or processing difficulties, spoken information can disappear quickly. A visual support remains available after the adult stops talking. Schedules can show the order of the day or the steps in a routine. A schedule could use words, pictures, photographs, symbols, or actual objects depending on the person's needs. A boundary can show where an activity happens or where materials belong. It might be tape on the floor, a labeled container, a sign, or a clearly defined space. A visual cue can remind the person what to bring, what to do next, what behavior is expected. For example, rather than repeatedly saying, get ready for school, a family could provide a short visual list. Get dressed, brush teeth, pack backpack, put on shoes. Visual supports can also help with changes. A calendar countdown, first then board, a picture or a new location can prepare someone for an appointment, a trip, having a substitute teacher, a family event that's coming, any change in their routine. The most effective visual supports are individualized. They should be understandable, easy to use, and used consistently. A visual support is not a punishment or something a person should have to earn. It's an accommodation. Positive behavior supports focus on prevention, teaching, and reinforcement. Instead of waiting for a problem and then reacting, we ask what support could reduce the likelihood of the problem occurring in the first place. We also ask what skill the person may need to be taught. Choice making is one example. Choices can increase participation and provide a sense of control. The choices should be limited and acceptable to the person with an FASD and to the adult providing them. For example, would you like to take your shower before dinner or after dinner? Is more manageable than asking something like, what do you want to do tonight? A 5-point scale can help make emotions, behavior, or expectations, again, those things that are not concrete, more concrete. A person might use a scale to show how anxious they are, how angry they are, how overwhelmed they are, or how tired they feel. Instead of asking that question for them to come up with a response, they could put that on a number scale. Each number can be connected to specific actions or supports. If I feel like I'm at a 4, what do I need to do? What can support me? Priming means preparing the person before an activity or a change occurs. You might explain what's going to happen, show pictures of where you're going, review the expectations that may be different, practice the routine that's happening, or discuss with the person what they can do if they become overwhelmed in the process. Positive behavior support also means noticing and reinforcing success. Individuals with FASD may receive frequent correction throughout the day. They need specific feedback about what they're doing well also. Instead of saying things like, good job, you can say, you checked your schedule and started the next step without a reminder, as a way to praise them. More specifically, you should also consider whether the expectation is realistic. If a person repeatedly fails at a task, the answer may not be a stronger consequence. The task may need to be taught differently, shortened, modeled, practiced, or supported in another way. Sensory processing refers to how the brain notices, organizes, and responds to information from your senses. Some people may be extremely sensitive to noise, lights, crowds, smells, touches, movement, or certain clothing. Others may seek additional movement, pressure, sound, or physical activity to remain alert and regulated. A crowded store, a loud classroom, a family gathering where everyone's talking, a medical waiting room, or busy community event could be overwhelming very quickly. When a person is overloaded, their ability to understand language, make decisions, regulate their emotions, and use learned skills can be decreased. Sensory supports can include things like planned breaks, quieter spaces, headphones, movement, fidgets, comfortable clothing, reduced lighting, or changes to the environment. A sensory break might not be presented as punishment or should not be presented as punishment. Ideally, the person learns to recognize early signs of overload and request support before reaching a crisis. We also need to remember that not every tool works for every person. A weighted item, a fidget, or a pair of headphones should be selected because it meets an individual need, not just because it's commonly called a sensory tool. The goal is to help the person reach a level of regulation where they can participate, learn, communicate, and feel safe. Prevention is an important part of FASD work. The prevention message is that there is no safe amount, safe time, or safe type of alcohol use during pregnancy. None, zero. At the same time, prevention messages must be delivered carefully and without shame. Pregnancies are not always planned. A person may consume alcohol before knowing they are pregnant. Some individuals may have a substance use disorder and may need treatment rather than judgment. Others may receive inaccurate or inconsistent information about alcohol use during pregnancy. There are still physicians saying that you can have one and zero alcohol is the standard. Partners, families, healthcare providers, and communities also have roles in prevention. This should not be treated only as a responsibility of an individual pregnant woman. Healthcare providers can ask about alcohol use routinely, provide clear information, and connect people with support when needed. Communities can improve access to treatment, prenatal care, mental health services, contraception, and recovery supports. Prevention and support for individuals already living with FASD are not competing priorities. We need both. The statement on the slide reflects harmful attitudes that birth parents may encounter. Statements such as, she doesn't deserve children, or if she cared, she would stop, reduce a complicated situation to blame and character judgment. They do not account for addiction, trauma, mental health, coercion, poverty, lack of information, lack of health care, or any multitude of other barriers. Shame can make people less likely to disclose alcohol use, less likely to seek prenatal care, less likely to ask for treatment, or provide information that could help a child receive an accurate evaluation. A birth parent's history may also be the information that helps professionals understand the child's needs. Families formed through adoption, foster care, guardianship, or kinship care may have limited information about prenatal history. They may also be navigating their own feelings while trying to support the child. An FASD-informed approach supports the child without dehumanizing or blaming the birth family. We can communicate the prevention message clearly while still treating people with dignity. Compassion does not mean pretending prenatal alcohol exposure has no consequences. It means recognizing that judgment does not prevent FASD, diagnose FASD, or help families succeed. The FASD Respect Act is a federal effort intended to increase awareness, improve diagnostic capacity, expand services, and support research related to FASD. One of the major challenges in FASD is that families may recognize that something is wrong but have nowhere nearby to go for an appropriate evaluation. Even after identification, they may struggle to find healthcare providers, therapists, educators, or community professionals who understand FASD. Public awareness is also needed because many people still think FASD always involves visible facial characteristics or always involves intellectual disability, and that's just not true. A central clearinghouse for evidence-based information could help families and professionals locate more consistent resources. Research is needed across the lifespan, not only during childhood. Adults with FASD may need support related to healthcare. They do. Employment, housing, relationships, making decisions, and community living. Policy matters because individuals, families cannot create diagnostic clinics, train entire service systems, or fund national research on their own. Families need systems that recognize FASD and respond appropriately. As we close, want to return to the main ideas from today. First, FASD is common, lifelong, and under-identified. Second, it's a brain-based disability. Behaviors that look careless, oppositional, irresponsible, or manipulative may reflect difficulties with things like memory, processing, language, ability to regulate, judgment, or generalization. Third, development may be uneven. A person can speak very well or perform strongly in one area while needing significant support in another, and that other may not be something you can see. Fourth, simple supports can have a major impact. Visual information, predictable routines, concrete language, using repetition, positive behavior supports, sensory accommodations, and realistic supervision can reduce frustration and improve success. Finally, prevention and policy are important, but so are compassion and ongoing support for individuals and families already affected by FASD. The shift I hope you remember is from asking, why won't this person do what they know how to do, to asking, what is making this difficult, and what support would make success more likely. Understand the brain changes our response, and when our responses change, the outcomes can change. Let's see. I'm going to move to the next slide that has information about how to contact us at HTC, joining our Louisiana FASD chapter, or contacting me. As I do that, you may type a question in, unmute to ask a question or have a discussion. Again, please don't share names or identifying information in a group setting, but you will have my email. Let me move over for that. Just want to again say thank you for spending part of your day with me learning about FASD. The Human Development Center's FASD Initiatives webpage includes additional information and resources. We are building a Louisiana FASD chapter. We are meeting. I'm sending out those meeting requests and trying to do that monthly. September is FASD Awareness Month. We will be trying to do awareness events across the state. If you would like to just be in the know, join that Louisiana FASD chapter, that JOT form information there. And I can send that separately in a link if you would like that, so that you can just click it. It's really just to get your information to get on the mailing list that I send out. So let's see here. My email address is listed on the slide. Please feel free to contact me after today's webinar, especially if you have a personal or a situation specific question. Let's see. And thank you again to Families Helping Families Region 7 for inviting me, and to each of you for being in here. Increasing understanding is one of the most important steps that we can take toward creating better outcomes for individuals with FASD and their families. Let's see, Sharon said, what are some other diagnoses that people with FASD could be incorrectly diagnosed with? I'm sure autism is common, and it is common. And some of the reasons why they would be diagnosed with the same thing are different causes. And so the supports that are put into place that work for autism aren't going to work for a child that has an FASD diagnosis necessarily, because the reasoning behind those deficits, even though they're similar, is different. You know, one's a brain-based difference. But I have definitely seen things like ADHD also being, ADHD and autism are also a comorbid, usually diagnosed, sometimes diagnosed together. I'm not diagnostic. I have grown my little professional self in the school system, so please don't take anything I say as medical diagnoses. I am here mostly on the education side of things, but I, I would say probably we have a lot of kids with oppositional, maybe not ODD, but just like oppositional issues that may need to have their prenatal exposure looked at, and may have some of those brain-based differences. But definitely autism and definitely ADHD. If you have any other questions, feel free to unmute and chat, or put a chat in. I may have missed this information, so I apologize. Where can you go get an eval? I need to get information together for you for that, to be honest with you. I don't know if everyone's able to read the chat. If you are staying on to chat, thank you. If you're not, you're gonna go. Thank you very much for being here. Sharon asked us where to go to get a diagnosis of FASD. We are developing a clinic. It's an add-on to our current, what was an autism diagnosis clinic, is now called NEST. So it's neurodevelopmental. And they're going to be diagnosing multiple things, not just autism and not just FASD. I believe ADHD is in that also. In New Orleans at LSU Health. I believe it is for littles, though. I don't believe it is for anyone outside of the age of 5. I'm going to have to look. I'm not on that. So I'll have to look at the ages. But I will have gotten together information about diagnosis closest to Louisiana and send that out along with these slides in PDF format to Miss Jackson, so she can send it out to everyone that was registered today. I want to make sure I get you the best, most up-to-date information. And we are going back to the Capitol to lobby might not be the right word, go meet with legislators for funding. I was in DC last year for the bill to pass, and now we're going to be going back for funding. Yes. Okay. So Sharon is saying it seems like there are a lot of physicians and pediatricians that are still very much unaware of this health crisis and unable to assist patients. And yes, that is true. We would see it as a health crisis because 1 in 20. That is another reason why, now that bill passed last year, that we are increasing our awareness. We're increasing opportunities for physicians to get trained. As I was talking about, that it is difficult for a lot of physicians. Maybe they don't have guidance published yet, but on how to talk to families about this sensitive subject, especially birth families, without sounding judgmental or being judgmental. So a lot of that training is going out there. We are developing training for doctors, but sometimes doctors like to listen to doctors instead of educators. So getting all of that together and all of the training put together in a way that doctors can receive it has been one of the things that we've been working on.
Amy, I do have a question.
Yes.
So, what are some of the earliest signs of FASD that are often overlooked?
Oh, sorry, I'm still writing down reminders to myself to send that information. Um, Earliest signs of FASD. I don't know that I have a list of common things just because so the fetus is affected by the alcohol at different days of pregnancy, in different ways and to different degrees. And each woman digests and metabolizes alcohol differently. On top of that, they're now coming out with some research that shows that fathers drinking also can contribute to this. So, because it affects so many different areas, not just brain development, but like I said, heart development, kidney development. It's hard to say one specific thing or a list of specific things to look for, but I will look for that to see if someone has come out with that yet. Um, it may be in different areas that you would be looking at different deficits that might cause you to want to go get a diagnosis. But I will look into that and make sure I have complete information for you.
Okay, thank you. And I know we talked about this a little earlier, but just so you can kind of like, say it in the webinar, can a child with FASD qualify for special education services?
Yes, yes, we are definitely going to be able to qualify kids for FASD. It isn't listed as an exceptionality in a Louisiana IEP. I know we're looking to Alaska for a lot of the movement that they've made forward with FASD, so that hopefully we can get an exceptionality approved for Louisiana for that to be part of their IEP exceptionality. I believe right now it would fall under OHI or other health impairment. But yes, yes, definitely it can be, and that's the reason why we're putting this out there. So that again, we're also working on a sort of a facilitation guide for teaching school systems about FASD and how to work with children with FASD as part of our FASD initiatives group. So that is being developed, hopefully to be dispersed, in the next year or so. But as we got the bill passed and as funding hopefully will get approved, you know what I mean? You'll be seeing more roll out as far as support, prevention, all of that diagnosis goes. Yeah, I would assume, let's see here, Sharon, I would assume that unless there is another DD diagnosis, they would not qualify for DD services like waiver. I will look into that and make sure I give you the most up-to-date information on that too.
All right, Amy, I want to thank you again for your time. If anyone has any more questions, you can put them in the chat or raise your hand. And I just want to remind you guys, don't forget to fill out your evaluation. Let us know how we did. Let us know if this information was very helpful to you, gave you a better understanding. Also, if there is any other topic that you would like for us to present on, please be sure to comment that on your evaluation. Again, I will be mailing out the link to the recording of this webinar, so you will be able to watch it again and just to digest the information in case you missed something. Because if you're like me, I have to watch something twice because I missed something the first time. So I'll definitely be sending out that link to you guys. And I'm giving you time back, so you have 7 more minutes added back to your day. So again, thank you, Amy, for your time. Thank you for your wealth of knowledge and your information. And
Yes.
thank you, everyone, for attending. And we will see you at our next webinar. Bye, guys.
Thanks. Bye.